Good evening, everyone, and welcome to this evening's webinar, Modern Management of Keratoconus. On behalf of everyone at Eversight, we'd like to thank you for joining our program. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question in the Q&A panel at the bottom of your screen. We will address all questions at the conclusion of the webinar. At this time, I would like to introduce our speaker for the evening, Dr. Stephen Greenstein. Dr. Greenstein is a graduate of Harvard's Cornea, Refractive, and External Disease Program and completed a Cornea Refractive Fellowship at Massachusetts Eye and Ear at Harvard Medical School. During his time at Harvard, Dr. Greenstein had the honor of being awarded the prestigious Heed Ophthalmology Fellow Award. Dr. Greenstein was one of the 20 graduating ophthalmology residents to receive this award. Dr. Greenstein received his medical degree from the Albert Einstein College of Medicine, where he graduated with a special distinction in clinical research. Dr. Greenstein completed an internal medicine internship prior to the start of ophthalmology resident training at Rutgers, New Jersey Medical School. Prior to and during his professional ophthalmic career, Dr. Greenstein worked closely with Dr. Peter Hirsch and the CLEI Center for Keratoconus in the research department, where he concentrated his research on keratoconus and corneal cross-linking. Dr. Greenstein published a multitude of articles in prestigious medical journals, including Cornea and Journal of Cataract and Refractive Surgery. On CLEI's corneal cross-linking clinical trial for the treatment of keratoconus and corneal ectasia. In addition to publications, he has presented at numerous scientific meetings. Dr. Greenstein has written many book chapters, including chapters in cornea, fundamentals, diagnosis, and management of the primary references for cornea surgeons around the world. Dr. Greenstein is a clinical assistant professor at Rutgers, New Jersey Medical School, where he teaches future eye surgeons about LASIK and other refractive surgery procedures. He is currently a member of the American Academy of Ophthalmology, American Society of Cataract and Refractive Surgeons, the Refractive Alliance, the Cornea Society, and the Society of Heed Fellows. Dr. Greenstein is also a team ophthalmologist for the New York Jets football team. Without further ado, I'll give you all Dr. Greenstein.
Well, thank you so much for that really kind introduction. It's really great to be here tonight talking about modern management of keratoconus. I really appreciate and I feel privileged to have this opportunity to talk to so many corneal surgeons about this topic. So these are my financial disclosures. They all do have some relevance to the talk tonight. So as everybody knows, keratoconus is generally considered a progressive, bilateral, asymmetric disease, which is clinically non-inflammatory. So we say now clinically non-inflammatory as opposed to what we used to say, which was that it was just generally a non-inflammatory disease, because research and recent research has shown that there are probably a lot of inflammatory mediators within the cornea as well as within the tear film, which do contribute to some of the pathology that we see in keratoconus. But still, clinically, when you look at a patient who has keratoconus, they don't have signs of ocular inflammation. So while there are definitely inflammatory components of the disease, it is clinically non-inflammatory. And as we all know, keratoconus stems from a loss of biomechanical strength, which is due to a focal thinning and steepening of the cornea, which leads to irregular topography. And what we're learning more about is the genetic components of this disease, as well as the environmental components. So starting with the structural changes in keratoconus, in general, keratoconus is a disease which affects the anterior stroma of the cornea. There have been multiple studies that have found different changes in the stromal architecture in the keratoconic cornea. There's decrease of the lamellae, which insert into Bowman's layer. There's a rearrangement of some of the vertical and horizontal lamellae, and generally there's a decrease of the lamellar interweaving, again, particularly in the anterior stroma, which is what contributes to most of the corneal strength and integrity. What has really been interesting is looking at the biomechanics of the keratoconic cornea, and our understanding of corneal biomechanics and keratoconus have really changed over time. And this is a study that was done using Brillouin microscopy to look at the biomechanics of the cornea. And the nice thing about Brillouin microscopy is that it allows us to look at the cornea in different sections and really identify the areas of biomechanical weakness in the cornea. Some of our other tools that we use to identify corneal biomechanics really only give us a general understanding of the biomechanics of the entire cornea. But Brillouin microscopy allows us to really hone in on the areas of weakness. And if we look at the graphs down below, what you can see in the graph on the left is that is the general biomechanics and the biomechanical strength of a normal cornea. If we look over at the graph all the way on the right, that's the strength of the keratoconic cornea in an area other than the cone. And what you can see between the graphs on the left and the graphs on the right is that overall, they're pretty similar. So what we started to learn was that most of the keratoconic cornea biomechanically was actually relatively normal. If we look at the graph in the center, we can see clearly in this area, which is the area of the cone, the area of steepening, there is a clear loss of biomechanical strength. And so we started to develop this knowledge that really the loss of biomechanical strength in the keratoconic cornea is specifically over the cone. And we can use some of that to our advantage when we talk about certain treatment modalities that we've developed over time. Now, in terms of how patients get keratoconus, we know that there are multiple contributing factors to any patient who gets keratoconus. There are environmental factors, most notably mechanical factors such as eye rubbing. Clearly, eye rubbing is something that can make keratoconus worse. It is something that we all counsel our keratoconic patients to avoid. There are many associated diseases with keratoconus, some of which may in part induce eye rubbing because of allergic reactions in the cornea, and some of which may directly contribute to some of the biomechanical weakness of the cornea itself. And finally, there are the genetic components of keratoconus, which we are just beginning to explore and learning how to use clinically. So one of the newest portions of keratoconic management is genetic testing for keratoconus, which is now commercially available through one company, Avigen. And there is a cheek swab, which can be done on any patient and sent for analysis. And what we know is that there are more than 70 genes that actually contribute in some way or another to the development of keratoconus. And some of those genes contribute more than others. And so what has been developed is a keratoconic risk score, which is then divided into 3 categories of low, moderate, and high risk. And through this cheek swab, a patient will receive results that look exactly like this slide here, which gives a specific number and then where that falls into your risk score. And what we're starting to try to develop is and learn from this is how to use this clinically. Clearly, patients, one of the most common questions we get asked from our keratoconic patients is, when should we have our kids screened? And we used to tell them to bring them in somewhere around the age of maybe 10 to 12, and we would do kind of a baseline topography for them, baseline refraction, and see whether or not there were any indicators that their child could develop keratoconus. But as we know, even at that age, that's would be the earliest age we'd probably see signs of keratoconus developing, and it could develop at any point after that. So this risk score may allow us to stratify some of those children and say, well, if your child falls into a lower risk category, maybe we don't have to screen them as much or follow them as closely in our clinic. And obviously in a high risk category, we might have to follow them even closer. And with the development of cross-linking, which we'll talk about later, clearly finding these individuals early and younger is very important to preventing getting more severe disease later in life. So this is a really exciting area of keratoconus management. It's something we're just in the infancy of and really just learning about, but it's something that we're starting to integrate into our practice. Now, the epidemiology of keratoconus has also significantly changed over time. The classic reporting of the prevalence of keratoconus was about 1 in 2,000. And this was based off of sort of our classic instrumentation, ultrasound measurements, refraction. But as our instrumentation has gotten better, we've seen numbers reported even as high as 1 in 84. Now, likely those numbers are based off of specific populations, but numbers like 1 in 400 seem like a more reasonable number nowadays for how many patients and the prevalence of keratoconus. And again, the difference in these numbers really comes from our change in diagnostics. The 1 in 2,000 number comes from classic diagnostics. And as we keep increasing that prevalence, it's really coming from our ability to identify more and more mild cases of disease. So we're all familiar with the signs that we would see at the slit lamp for patients who have keratoconus, things like Vogt striae, apical scarring, thinning, Munson sign, high drops, Fleischer rings. But really, what all of these things have in common is that these are really measures of very advanced disease. When you get to this stage of keratoconus, you are already very far along in your disease. And we are trying more and more to identify these patients earlier and earlier before any of these changes occur. So what we really know is that keratoconus and early keratoconus is invisible at the slit lamp. You would never know that you're necessarily looking at a mild keratoconic patient by just doing a slit lamp exam. And classical instrumentation definitely misses the disease. So we really need advanced diagnostics to diagnose keratoconus at an earlier and earlier time. And those have really developed and become more and more exciting as well. So classically, we know that we use topography. Topography has been the mainstay to diagnose more mild cases of keratoconus. And topography has evolved into tomography, where we can identify more about the shape of keratoconus, either through Scheimpflug images or OCT images. And when it comes to corneal topography, we have developed these metrics, which can help us sort of identify, is the topography we're looking at more irregular or regular? Is this something that would be suspicious for keratoconus? So we have cutoffs for the IS difference. We have cutoffs for the mean keratometry, maximum keratometry, the skew deviation. But even corneal topography alone still identifies cases of keratoconus at a more advanced state of the disease. So then we move on to corneal tomography, where we can now look at both the front and the back surface of the cornea, and we can identify cases even earlier. So this is clearly a case of classic keratoconus. Everybody here looking at the tomography would know that this is keratoconus. But what tomography allows us to do is really look at the anterior curvature of the cornea and then correspond it to the anterior elevation of the cornea, looking for those islands of elevation, corresponding to the area of posterior elevation, and also corresponding to the areas of localized thinning. So as we start to be able to look at the shape of the cornea at all of these different levels, we can identify earlier and earlier cases of the disease. And with artificial intelligence, we can now take regression analyses of the cornea itself. And one of these is the BAD analysis, or the Bell and Ambrosio enhanced ectasia display, which is available on the Pentacam. And this allows us to take a regression analysis of the entire cornea and actually subtracts out the 3 millimeters around the thinnest point to compare it to the entire cornea. And when you look at multiple factors, it then gives what is called a D-score. And that D-score is what is compared to the general population. And that's a constantly updating database. So when you compare that score to the general population, you can now say whether the cornea you're looking at is 1 or 2 standard deviations outside of normal, and even how outside of normal within those standard deviations that might be. So if it flags as yellow, for example, that means the cornea you're looking at least related to the D-score, is likely 1 standard deviation outside of normal. And once the cornea flags as red, it's 2 standard deviations outside of normal. And so you really have the confidence that you're starting to look at more and more irregular corneas. Our ability to classify keratoconus, because of our ability to now image keratoconus, has also really evolved. So still to this day, the most used form of keratoconic classification is the Amsler-Krummek keratoconus classification. But as has been the theme so far in this talk, even these stages of keratoconus are really based in very classic instrumentation. So it's based off of mean keratometry, based off of refraction, particularly myopia and astigmatism. And what we've learned over time, looking at our own keratoconic population, and we've looked at thousands of eyes that we've seen with keratoconus, we've seen up to half the eyes have either a mixed astigmatism or even hyperopia itself. So just looking for increased myopia or myopic astigmatism is not enough even in advanced disease. And when we look at the thickness measurements, these measurements are also based in ultrasound thickness, which is just looking at the thickness of the cornea at one point. So really with all of these metrics, we could be missing pretty severe disease, which would be classified as even something like stage 2 in the Amsler-Krummek classification scheme. So now with our ability to look at the anterior surface and the posterior surface and the corneal thickness, we can look at the curvature in all of those areas of the cornea, particularly around the thinnest point. So if you look at a 3 millimeter zone around the thinnest point, you can look at the curvature in that area and again, start to stage keratoconus based off of how steep those areas are. And that's exactly what we do with the ABCD analysis. So when we look at an ABCD analysis, which is also on the Pentacam, what you can see is it analyzes and stages keratoconus at its anterior curvature, its posterior curvature, and its thinnest point. So on the first case, which I showed the tomography for, we can see that this would be staged as a 4+ anterior keratoconus, 4+ posterior keratoconus with a almost stage 2 thinnest point. A more mild case would be about stage 1 on the anterior surface, stage 2 on the posterior surface, and almost stage 1 in the thinnest point. And then a very borderline case, which is probably not keratoconus, maybe at best formed first keratoconus, would show that it is about stage 1 on the posterior surface. So this allows us to really communicate about what we're looking at and how we're classifying keratoconus with other surgeons and other doctors, and we know that we're really talking about the same thing. Now, the advancement of being able to focus around the thinnest point of the keratoconic cornea has also allowed us to then monitor patients much more closely for progression and identify earlier progression, which we can then treat with cross-linking. And so if we look more closely at this ABCD progression display, what you can see here is that the yellow line, the orange line, is the area of the baseline exam, the first time the patient came in, and the A is the anterior curvature, the B is the posterior curvature, and the C is the thickness at the thinnest point. And then on the next exam, the patient comes in, we can compare that to the baseline curvature. And then that gets compared to a keratoconic population. So the green is a normal population, and then the red is a keratoconic population. And what we can see is that there's a 95% confidence interval that on the anterior, posterior surface, and the thinnest point, this patient has progressed. And it's a really nice way to show a patient visually what's happening to their cornea and how their cornea is changing, and to be able to reassure us that when we're looking at changes on the topography or the tomography, that they do meet the criteria of progression. And there's even a third class of population that this can be analyzed with, and that is a post cross-linking population. So in blue, these are patients who have been treated with cross-linking, And what you can see is you can start to develop a staged progression analysis through each of a patient's visits. So this patient came in for 2 separate visits. Then they had cross-linking done, which is identified by the black dotted line. And then once they're a year out from cross-linking, that becomes their new baseline corneal measurements. And everything then gets compared to that new baseline measurement based on a comparison to a cross-linking population, which is in blue. And again, it's another way of both reassuring us that what we're looking at is stability or progression, and also comparing what you're seeing to a more general keratoconic and specifically keratoconic and cross-linked population. And the final area of diagnostics, which has really advanced is through OCT, is our ability to look at epithelial thickness. So what we know about keratoconus now is not only is the corneal thickness unique and that there is a localized thinning around the area of steepening, but there's also a thinning of the epithelium in that same area. So if you look at the OCT image on the right, what you see is the back surface epithelium is identified in red, and then the anterior portion of the epithelium is identified in yellow. And you can see that on the edges, so at the top and the bottom of the image, the epithelium is generally a normal thickness, maybe even somewhat thicker than normal. If we look right over the apex of the cornea, right over the steepest point, the epithelium becomes much thinner. And we can see this on the map on the bottom right, which has been kind of labeled this donut or bagel shaped pattern. What you see on the bottom right is the area of thinning. And in that area of thinning, there's an area of thickening around the cone of the epithelium and an area of thinning right over the cone. And this is the body's way of trying to smooth out the cornea as best as it can. And that's what gives kind of that donut shape appearance. And we're going to talk a little more about this when it comes to treatment and how this can also help us in our management of keratoconic patients. So while it's very exciting to talk about how our diagnostics have advanced and how we are able to identify patients earlier and earlier with keratoconus, this is only meaningful because of how much our treatment has advanced over time as well. So classically, traditional keratoconus management really broke into 3 categories. You were either correctable in glasses, and most of those patients didn't even know that they had keratoconus. Once you couldn't be corrected well in glasses, you were shifted to a specialty contact lens. And if you couldn't be fit in a specialty contact lens, which at the time was traditionally a rigid gas permeable lens, you moved on to corneal transplant. And those are really the 3 options for a keratoconic patient. But now, with the advancement of corneal cross-linking, we are really able to customize our treatments of keratoconic patients to meet the individual patient's needs. And we've kind of labeled the algorithm that we use and the way that we approach keratoconic patients in this label of KC123. And that identifies essentially the 3 things we look at every keratoconic patient to determine what is the best treatment approach moving forward. So the first and foremost, the most important thing is to stabilize the keratoconic cornea. At this point, I think we all are in agreement that corneal cross-linking is standard of care when it comes to treating progressive keratoconus. The first thing you must do is stabilize the cornea. The next is, how do we improve patients' corneal topography? And we have multiple surgical modalities to now improve patients' corneal topography. We have corneal inlays, which are continuing to advance. We have topography-guided PRK, which has really changed our ability to reshape the keratoconic cornea. We still have CK and conductive keratoplasty, which can be used in conjunction with other procedures to make the cornea more symmetric. And of course, there are still cases that require corneal transplant to achieve the best visual result. And finally, once we improve a patient's vision, we then need to once we improve the patient's topography, we then, of course, have to meet our main objective with all of our treatment, which is to improve patients' vision. and that can be done with glasses, with contact lenses. It can still be done with PRK, and even certain forms of lens implants. And our ability to use these surgical procedures to correct keratoconic patients' vision is very much rooted in the ability to stabilize the cornea and improve the corneal topography. So let's jump in a little bit more towards the keratoconus management, and particularly stability of the cornea with corneal cross-linking. So corneal cross-linking is a treatment which uses UV light in combination with riboflavin or vitamin B2, as well as oxygen, to create a photochemical reaction in the cornea, which results in the stiffening of the cornea. Essentially, we are creating additional bonds around the corneal lamellae to stiffen the cornea, very similar to adding suspensions to a suspension bridge, or some of these additions around a erector set to stiffen and give more corneal integrity to the cornea. Now, corneal cross-linking in the US was first done in 2008, and as we all know, was FDA approved in 2016. It remains that its indications are currently for progressive keratoconus in patients that are older than 14. I would say that most people agree that if you see a patient who is younger than 14 and still progressing and has keratoconus, they should be offered corneal cross-linking off label from these indications. Patients at that age are almost by definition progressive and are going to advance potentially very rapidly. And was also improved for corneal ectasia after refractive surgery. And what we found from the original FDA trial was that while the main goal of corneal cross-linking is, of course, stability of the cornea, we found that you do get a mild amount of flattening on average. So Kmax, the steepest point in the cornea, flattened on average by about a diopter and a half. We saw a general improvement in keratoconic indices, and uncorrected vision and best corrected vision improved by about a line after cross-linking. A little less on the best corrected side, it was a little bit under a line, and a little bit more than a line on the uncorrected side, and higher order aberrations improve as well. Obviously, it's important to tell patients so they have realistic expectations. The improvement of a line of uncorrected vision in a keratoconic patient is likely not to be very noticeable, and the improvement even of just under a line of best corrected spectacle vision is probably also not going to be very noticeable, but there can be exceptions where you get significant improvement in uncorrected vision and specular corrected vision, and those patients obviously are ecstatic with the result. Now, what's also important and very important for counseling patients is to understand the postoperative healing and the time course of that healing for patients, because what we found early on was that at 1 month after cross-linking was done, the cornea and the vision was actually worse. And as time went on, the cornea returned to baseline, usually around 3 months, and then began to improve between 3 and 6 months, which mostly stabilized out to a year. But it's these timeframes, the worsening at a month, and then the stability between 6 and 12 months, which are critical, both again to counsel patients that they are going to go through this up and down, and it might be noticeable to them, but also to stage our procedures so that we know that if we are going to treat a patient and improve their topography, and we're planning on doing that surgical procedure separate from cross-linking, that we wait for the cross-linking to become stable before doing our next step in treatment. And so it's important to tell patients that in the plan, there's likely going to be a wait of a minimum of 3 months, most likely 6 months, even out to a year, before any further surgical treatment might be performed. Now, some procedures can be done in conjunction, and we'll talk more about that, but others really do best with waiting. Now, what we looked at in our own center is the 10-year outcomes of the patients that we had treated as part of the original US pivotal trial. So we looked at these patients in our own center alone just to see how stable they were 10 years later. And what we found was that the results were really very encouraging. When it came to best spectacle corrected visual acuity, 86% of all the patients we treated remained stable, meaning their vision didn't change by or didn't worsen by more than 2 logMAR lines of vision. With the keratoconic portion of the population we treated, really 100% of those patients remained stable. In the ectasia portion, about 71% remained stable. When we looked at topography, and again, we defined failure or progression as steepening by 2 diopters or more of maximum keratometry, we found that just under 77% of the patients we treated were stable. Almost 87% of the keratoconic patients were stable, and about 2/3 of the ectasia patients were stable. Now, this did bring on a very important lesson for us and how we counsel patients. First of all, it's important to tell all patients that even after their cross-linking treatment, they need regular follow-up, because some of them, whether they're keratoconic or whether they have ectasia, are going to progress over time. And we haven't yet identified who those patients are going to be. So it does pay to have regular follow-up even after your cross-linking to make sure that your cornea has remained stable, especially since cross-linking is a repeatable procedure if there is some progression. But also interestingly, what we found was that our patients with ectasia after refractive surgery clearly were not as stable as those with keratoconus. And that is either due to the fact that ectasia after LASIK is a more aggressive disease, or maybe due to what we saw originally in the FDA trial, which was that the response to the cross-linking itself was somewhat less in this group than the keratoconic patients. And whether that was because the disease itself is somewhat different, or because of the location of the cones in ectasia, which tend to be more inferior and might not have gotten as much central UV light, is still really to be determined. But it really is something that has changed our counseling of patients, especially after they've had LASIK, which is to say that you should absolutely have cross-linking done. But your disease, as far as we see, is more aggressive than patients who have keratoconus and have never had LASIK done. And there is a higher need, maybe as much as 1/3 of the patients are going to need a second treatment. And so they should be aware of that, and they should know that they need regular follow-up for that. Now, the future of corneal cross-linking is also very exciting. We are eagerly awaiting the FDA results of the transepithelial cross-linking trial. Transepithelial cross-linking may offer our patients the ability to have cross-linking done with a much quicker recovery than the traditional epithelial off cross-linking. We're also looking at things like shorter UV light treatments with higher UV power and irradiation, new riboflavin formulations which don't dehydrate the cornea like dextran, but are more isotonic to the cornea, a custom cross-linking, either done in conjunction with a laser-guided cross-linking or an actually topography-guided cross-linking system, and alternative wavelengths of light, which may also induce a cross-linking and be able to be used in a more topography-guided approach. So once we have stabilized the cornea, the next component that we look at is how can we improve the patient's corneal topography? And by improving their topography, hopefully we can then improve their vision. So one of the mainstays and surgical treatments that we have to improve corneal topography are corneal inlays. And the main inlay that we use in the US is Intacs. Now, how do Intacs work, and why do Intacs actually reshape the cornea? So if you look at this Scheimpflug image of a patient after they've had Intacs placed, you can see that the original cornea is marked by the yellow line here. And then the Intact segment is the hexagon in blue. And what you can see is the new corneal contour shaped by the Intacs comes from the fact that there's an elevation of the cornea right over the top of the Intact segment. And then inside of the intact segment is where the flattening actually occurs. And this is really important for intact's placement because the actual action of flattening is not over the segment itself. It's right inside of the segment. And it's really pretty close to where the segment is elevating. So if this area of steepening is too far from the segment, you may not really get much of a result. You really need the segment to be able to get close enough to the steepest portions of the cornea to induce the desired flattening. And when we looked at our intact patients, we did a randomized prospective trial in which we compared patients who had intacts done simultaneously with cross-linking and patients who had intacts done first and cross-linking done 3 months later. Overall, we found that there was no difference between these groups, which is why when it comes to intacts, we generally do offer them at this point as a simultaneous treatment with cross-linking. And what we found is that on average in the groups, there was about 2.5 diopters of flattening. And there was a little over 2 lines of uncorrected, about 2 lines of uncorrected visual acuity improvement, and just over a line of best spectacle corrected visual acuity improvement. And this is definitely better than cross-linking for sure, but does leave still room for improvement in our ability to improve topography for our keratoconic patients. Now, what we also know is intacts really do create some challenges, and they create some challenges in contact lens fitting, which is somewhat why they've fallen out of favor. Because even if you can get a 2-line improvement, even if you get it in their best corrected vision, many of these patients still do rely on their contact lenses to get their best vision and most functional vision throughout the day. So there may be an advantage to having best spectacle vision that's 2 lines better, so they aren't as dependent on their lenses. But most of these patients do still require a lens to get that best vision, and fitting the lens over an intact segment can sometimes be challenging because it's really critical that the contact lens itself does not rub against the segment, because that's when we tend to see tissue damage and erosion. And we also looked at about almost 600 patients where we placed intact segments and looked at the percentage of those patients where we had to explant those segments. And what we found is that just over 6% of the 593 intact patients where we placed intacts in our own center, we had to explant those segments. And 23 of those, 3.5%, were for optical reasons. They were either subjectively their vision was worse or objectively their vision was worse. They had additional glare, halo, some complaint that we could not fix. And just over 2.5% were for medical complications, either infection or more commonly sterile erosion and inflammation around the segment. So this is also very helpful in counseling patients when you do place intact segments. It is helpful to tell them that about 5 to 6% of the time, the segment does have to be removed. Although what we have found is that once it is removed, the cornea generally returns back to its original shape, and it is a reversible procedure. Now, there are many centers looking at corneal tissue inlays, and this does potentially have the ability to change the keratoconic landscape when it comes to inlays, because corneal tissue clearly will provide improved biocompatibility than synthetic segments. It doesn't have the limitations of treatment in thin corneas. So when you're using corneal tissue, you can place the inlay in thinner corneas. And really, it does not have as much of a limitation in severity of disease, because these tissue segments can be cut to many different thicknesses and lengths to treat different keratoconic patients. And there are multiple reports of different types of these tissue inlays. There's Bowman layer transplants. There's femtolaser intrastomal lenticular implantation, where lenticules, some of them outside of the US, created from SMILE procedures, which are placed in a pocket of a keratoconic patient, and corneal allogenic intrastomal ring segments, which are corneal tissue that is shaped in the shape of intact segments to create a similar effect. And we're looking forward to the results of these different type of inlays, which really do show a lot of promise for treating more severe disease in the future. Now, one of the most exciting areas of topography improvement for keratoconic patients is topography-guided surgery, and particularly topography-guided PRK. Now, topography-guided LASIK was approved by the FDA in 2016, and topography-guided PRK in general, whether a patient is keratoconic or not, is an off-label use of the system. But topography-guided PRK in keratoconus is obviously off-label as well. And the way that the system works is that we use placido imaging to generate a topography map. And we load that topography map into the laser and develop a treatment plan, which will then flatten or steepen the cornea in specific areas to make the topography a more regular shape. So what you see at the bottom is exactly what we see in the office, which is we generate a placido image, which generates a topography map, which you can see in the bottom right, and then a treatment plan is developed, which you can see on the right, where there's different areas of flattening and steepening to make the cornea a more symmetric shape. And there's really two different approaches you can use for treating keratoconic patients. And we have found that the transepithelial approach really does offer certain advantages when we're treating keratoconic patients. Standard PRK, which we all do or know about, requires manual removal of the epithelium or a laser removal of the epithelium in a 9 millimeter central zone, and it removes that epithelium evenly so that the laser itself treats directly on top of the stroma. And what you can see in my diagram on the top right is that if you do that in the keratoconic patient, you're going to treat the cone and around the cone evenly, which may cause still some additional irregularity in the cornea, particularly because when you unmask the cone, the topography is actually different than the topography that you're getting in the contour system. So on a normal cornea where the epithelium is smooth, the topography is likely very repeatable. But in a keratoconic cornea, that's very different. And you can see that if we look at the bottom left, again, if we look at the diagram that I drew in the bottom left, you can see how the epithelium in blue masks the cone. It masks the steep portion of the cornea with a thinner epithelium over the top, which is what I showed before. The purple area is then surrounded by the hypertrophied epithelium around the cone. And that creates actually a perfect mask for treating a keratoconic cornea. And what happens is if you use the laser directly over the top, you're actually going to hit the cone before you hit the surrounding tissue. And that can be very helpful in your treatments. So some of the advantages of transepithelial PRK is that the PRK can limit corneal thinning, and it can limit some of the myopic shift that we've seen in treating keratoconic patients. So how does it limit corneal thinning? Well, one of the limitations of the system is that when you develop a treatment plan based on the patient's refraction and their topography, you become limited to how much the laser wants to remove in corneal tissue to achieve the desired result. And you can't really adjust that except by adjusting the treatment plan. And in keratoconic patients, even a plano treatment in topography-guided treatments can treat as much as 70 microns of the cornea. Now, if you leave the epithelium intact, so if we look at our example, which I showed a few slides ago, the maximum treatment here and the maximum depth of the laser is about 97, almost 98 microns. That is a lot of tissue to remove in a keratoconic patient underneath their epithelium. If we take their epithelium into account and do a transepithelial approach, you can see that the epithelium over the cone is about 45 microns, which means that the total tissue that we remove is about 53 microns. So we've reduced the maximum treatment of the laser from 98 microns to 53 microns, which does also limit how much flattening you get, but it allows us to treat more advanced patients, which we would not be able to treat if you remove the epithelial surface. In addition, we can limit the myopic shift. Now, I had some animation here, which I'm not sure is actually going to work on Zoom. It looks like some of it will and some of it won't. So we'll see. But what you can see is if we look at the ablation profile on the left, if you look at it very carefully, it's very similar to a hyperopic ablation profile on the right. Actually, very little of the treatment is going to happen in the center. You're going to get an arc up top. You're going to get some central treatment over the cone, and some of that is also going to be in the mid-periphery. So what we found in our early treatments of keratoconic patients is that if you treated them with the arc up top, you would get a pretty significant myopic shift. Their vision would be much more correctable, but they could shift 5-6 diopters in their treatment, and patients weren't very happy with that. Now, if we look again at that epithelial map, what we see is that the area around the cone is thicker. And so it's about 61 microns, which is exactly what the laser wants to remove in the arc segment, about 62 microns. So really, if you run the laser here transepithelially, what you'll essentially do is block the entire arc. It won't actually penetrate into the stroma. And then what you get is a more direct treatment in the center over the cone, which is much more similar to a more customized astigmatic treatment. So you can take a treatment which is more hyperopic and then shift it to one that is really directly over the cone with less myopic shift. So the transepithelial approach can be very helpful in patients with more advanced disease. Now, we looked at about 25 patients that we treated with keratoconus and topography-guided PRK. And here we started to see some real improvement in their vision. We saw a significant improvement of about 3.5 lines of uncorrected vision. And that was a big difference for patients. And even in their best corrected vision, although it didn't reach statistical significance, we were really improving patients' vision from about 20/40 to 20/30 and getting a really consistent, better glasses vision. And as we've refined this process, we actually expect to see even better results. How much were we thinning the patient's corneas? So we were flattening them on average by 4.7 diopters, again, more than with intacts, more than with cross-linking. And to do that, we were removing on average about 40 microns of tissue. So that's why it is critical to be able to do cross-linking and stabilize these patients' corneas, because we are going to make these corneas somewhat thinner afterwards. Now, finally, we still have to deal with the patients who develop scarring, significant scarring, and acute hydrops. And a lot has come out about treating hydrops more acutely and aggressively. There have been thoughts to do DMEC on these patients to close the Descemet's tear, suture the tear, use gas or air to tamponade the tear. All of these things have been used with variable success. It definitely can decrease the acute swelling and probably limit some of the scarring. There can be some other side effects of IOP changes, cataract and things like that, which can develop from doing this. So the jury's still out. We're still learning whether acute intervention in hydrops versus observation is the way to go. But really, scarring in general has become kind of the main reason that we use corneal transplants for patients with keratoconus. And what we see in the data over time is that, as we know, penetrating keratoplasties in general have been decreasing. But the reason for that is mostly because endothelial keratoplasties, DMEC or DSEC, have really taken their place for endothelial disease. But what we haven't seen is much of a change in our lamellar keratoplasties, anterior lamellar keratoplasties, particularly DALK. Now, one thing we've seen, which was studied outside the US, was that once cross-linking was used more frequently, there was a definite reduction in penetrating keratoplasties done. And this was a study that was done in the Netherlands, which we saw a 25% reduction in corneal transplants once cross-linking became very prevalent. And we've seen kind of a similar trend in the US, where between 2016 and 2019, ectasia actually went from the #1 indication of penetrating keratoplasty to the #2 indication, some of which moved over to DALK, but much of which has also been because of cross-linking, as we've also seen a reduction in DALK procedures as well. Now, DALK we generally like to use in keratoconus because it allows us to preserve the endothelium, and we generally, like I said, use this for cases of visual axis scarring. There is still a role for penetrating keratoplasty for sure in full thickness scarring, particularly cases of hydrops or patients that might have combined endothelial pathology. Now, a recent meta-analysis review was published on PKP versus DALK. And one of the things that was found, which I think is not surprising, is that the adverse outcomes of PKP versus DALK were higher, particularly significantly higher of cataracts, graft rejection, and increased intraocular pressure. And this makes sense as the full thickness graft doesn't have a stable chamber and can affect inside of the eye more than a DALK will, where the chamber is maintained throughout the procedure. What was also found was that DALK had better outcomes when it came to improved endothelial cell count and for spherical equivalent, and likely penetrating keratoplasty still does have better outcomes when it comes to the final visual result, as there's no interface really haze or changes at all. And maybe with the topographic cylinder and the refractive cylinder as well, although in the meta-analysis, none of those were statistically significant. Now, why hasn't DALK been more accepted? It definitely is because it takes longer to do and it is technically more challenging. Now, there are different techniques that are used. Some have made it more repeatable than others. There's manual dissection, the big bubble technique, which is definitely the most common technique to do DALK. There's a technique called groove and peel, and one that, for an interesting way of terming it, but it is termed as the grip and rip. Those two do leave some level of stroma behind, which does make the procedure more reproducible, but may also make the visual results slightly inferior to the big bubble. And where we can really see some advancement potentially in DALK is with the femtosecond laser. And there have always been some thoughts that the femtosecond laser may add some additional benefit to keratoplasty in general. Again, the jury is still out on this, but the thoughts have been always centered around the different cuts that can be made, whether it be the zigzag, the top hat, the mushroom. They may promote a faster wound healing than having a 90-degree cut, which can facilitate earlier suture removal, and may also have because of the connection between the donor and the host with these cuts and the wound apposition, there may be a reduction in some of the corneal astigmatism as well. There's been a mixed results when it comes to these things. It probably does promote somewhat of a faster wound healing. Whether that affects astigmatism is still unknown. But where the femtosecond laser can be very helpful is potentially in DALK procedures, because if we can get a more reproducible and predictable depth on our cut, and particularly if we can get an OCT guided depth on our cut and also on the channel created for the big bubble, where we know that we get a channel very, very close to decimase, we might be able to then start doing DALK in a more reproducible way for these patients. So this is an area of interest of ours, and it's something that we are working on more and more, and we hope to be able to talk about some of those results in the future. And finally, once we stabilize the cornea, once we have improved corneal topography, we really want to improve patients' vision. Now, if we can do it with glasses, that's fantastic. Sometimes we can do some additional PRK to improve their vision. That's done on a very limited basis. But there's also been tremendous advancement in contact lenses, and particularly in the customization of contact lenses. Our ability to customize soft lenses has allowed us to treat more mild cases of keratoconus with soft lenses for patients. And really our ability to customize scleral lenses, whether that be with imaging and scan-based technology or impression-based technology, where a mold is taken of the eye and the cornea and the lens is then printed from that mold, there are really very few limitations to fitting a scleral lens anymore on a patient's cornea, which is why I say corneal transplant at this point is very much reserved for patients who have corneal scarring, where a contact lens is not going to improve their vision. But we really no longer see corneal curvature as a limiting factor because of the advancement of scan-based and particularly impression-based customized scleral lenses. And finally, with our ability to stabilize the cornea and our ability to improve corneal topography, we now also have the ability to use intraocular lenses to improve patients' vision as well. And we have phakic intraocular lenses. Most commonly in the US, we use the STAR ICL, implantable columnar lens. And of course, when patients have cataracts and require cataract surgery, we can use monofocal and now more often toric lenses if the topography is regular enough to improve patients' uncorrected and spectral corrected vision. Still, multifocal and extended depth of focus lenses really need to be used with extreme caution. They really are difficult to use in these patients given the multifocality of the cornea. And so the Visian ICL is generally indicated for myopia and particularly moderate and severe myopia, but also has a toric availability, which allows us to treat our keratoconic patients off-label. And it's very important for the patients to have a regular astigmatism and to be correctable in spectacles to benefit from these toric lenses. So I want to just close with this final case, which I think kind of sums up a lot of what we went over today. And this is a patient who we saw in our office. Now, he was 33, he had keratoconus in both eyes, but frequently what we see is what you see here, which is that he has very asymmetric disease and asymmetric and anisometropia with an asymmetric spectacle vision. He's 20/80 in his spectacles in the right eye, 20/25 in the left eye, with severe myopia and astigmatism in the right eye, and actually a mixed astigmatism in the left eye. And you can see why, because his topographies and his disease is very asymmetric, more severe in the right eye. So we stabilized his cornea with cross-linking. Then we moved on to the second phase of improving his topography, where we did intacts, and then we did PRK over the top of his intact segment. So we ended up with a more regular, flatter cornea and better correction. So after he had the PRK done, he now corrects in his glasses to 20/25, which is great. But he's still stuck in this situation with glasses where he has significant anisometropia, and his uncorrected vision is significantly better in the left eye than the right. So we then moved on and we placed the ICL for him. And now he really was able to have a very balanced vision. He has 20/25 vision in both eyes, 20/25 and 20/30 uncorrected, 20/25 in his glasses, and his refraction is much more symmetric. So what I hope you have seen tonight is that keratoconus is really advancing at a rapid pace. The diagnostics have advanced at a rapid pace, and the treatments have advanced at such a rapid pace that it is really critical to diagnose keratoconus early, particularly with advanced diagnostics, and hopefully we're going to learn more and more about genetics. It's important to stabilize the cornea early with cross-linking and avoiding eye rubbing. And once we do that, we can really customize treatments now for keratoconic patients to meet them at many of their different needs. So thank you very much again to Eversight for giving me the opportunity to speak tonight. I know that we kind of pressed right up against the 8 o'clock deadline, but I am happy to answer some questions if we have any.
Great presentation, Dr. Greenstein. Thank you so much. As a reminder, if you have any questions, please type them in the question and answer box. I do have a couple for you. As patients are getting diagnosed at younger ages with keratoconus, what is the youngest age you are comfortable with performing cross-linking?
The youngest we've done it here is actually 10. That's the youngest we've done it. I think it's hard to do in the office setting at younger ages, obviously, because it's hard to do it on a patient that age awake. I know that there are places doing it even younger than that with general anesthesia, and I don't think that's wrong either. When you find it at those ages, you want to treat it as early as possible.
Okay, thank you. The next question, is genetic testing for keratoconus readily available?
Yes, it is commercially available. It's something that is set up. You do the swabs in your office, and then you send it to their lab. and then they will produce and give you back the results to give the patient. And then they also offer genetic counseling. So, they obviously, whenever you're doing genetic testing, it brings on a lot of questions for patients, some of which you might feel comfortable answering, but some of which you might refer the patient to genetic counselors, which are provided once they do the testing.
Okay, next question. For patients with post-LASIK ectasia, are you doing CXL right away, or do you wait for progression? And the second part of that question, how long do you wait before repeating topography?
Yeah, so it's a great question, and this comes up with young patients and the post-LASIK patients. So from the standpoint of what I think should be done, I think those patients should be treated generally right away. I think from what we've seen with post-LASIK ectasia, both the numbers and the 10-year outcomes and just what we've seen in our own practice, those patients definitely appear to have a more aggressive disease. And so I think cross-linking them early is very important to try to stabilize their disease. In the same way, I think that cross-linking young patients, particularly patients under 21, very early is really important. Now, for certain reasons, sometimes you have to be able to document progression to be able to do cross-linking. And of course, that has to be factored in. But I do think that they should have cross-linking done as soon as possible. Well, at the beginning, we do repeat their topography at 1 month. We usually see our cross-link patients back at 1 month, 3 months, 6 months, and a year. We've kind of kept that going from when we participated in the FDA trials. And we do repeat topography at every one of those exams, mostly to see the healing process, the steepening, the flat, and then the flattening. Once they get out to a year, we generally repeat it every 6 months. As they become more stable, out to 5 and 10 years, some of them I will extend out from there, but it takes a while to extend from the every 6 month check.
Okay, one more question. Do you utilize autologous serum tears to aid in recovery post cross-linking?
We do not use that on a regular basis. No, we don't. For most of these patients who are young, we do not find that we've had significant problems with epithelial healing. There definitely can be some. So I would definitely use it if I saw delayed healing in any way, but I don't use it on a regular basis.
Okay, there doesn't appear to be any additional questions. So this will conclude our webinar for this evening. This presentation has been recorded and will be available for on-demand viewing on our website. A very big thank you to you, Dr. Greenstein, for providing us with your invaluable expertise on this subject. Thank you so much.
Thank you again for having me. Have a good night, everyone.